I'm Chelsey White.
I'm Adrian Williams, and our project is a grade 2 eversion ankle sprain.
All right, Jack is a 20. Our patient is Jack. He's a 27-year-old car salesman who plays intramural soccer on the weekends. He was playing a game when he sprained his left ankle when another player from the other team did a sliding tackle and forcefully everted his foot. He reports his pain as a 4 out of 10 when resting, but when when he's on his feet, it's a 7 out of 10. The patient has limited range of motion and decreased strength when compared bilaterally, and his left ankle also has a girth of 26 centimeters when compared to his right, which has a girth of 21 centimeters. So Jack injured his left ankle. So these are his range of motion and his strength when compared to his right. In his left ankle, his plantar flexion is 35 when his right is 48 degrees, and then dorsiflexion is 10 degrees, eversion is 7, and inversion is 30. So you can see that he has decreased range of motion when compared to the right side. That can have to do with his pain, with the increased swelling in his left ankle. And then when you look at his resistive range of motion, he has in his left foot, he doesn't have a 5 out of 5 on really anything, so we're going to work on getting those back to normal, because when compared to his right foot, he has 5 out of 5 on all. And okay, so Jack has a grade 2 ankle sprain, which means that he has a partial tear of the deltoid ligament. Since he did an eversion, this is going to be on the medial side of the foot. The deltoid ligaments include the posterior and anterior tibio-talar ligaments, the tibio-calcaneal ligament, and the tibio-navicular ligament. The partial tear of these ligaments can cause ankle instability, so abnormal gait can occur. And then our precautions would be tendon tears or tendinitis, or we can have avulsion fractures of the tibia. So since this ligament is so strong that when it tears, it can actually take a piece of the tibia with it. All right, so our treatment options, we have operative and non-operative. Operative is only indicated when you have a chronic instability, so they chronically are spraining their ankle, they can't get it to stop. Our recovery time for operative is 3 to 4 months when compared to non-operative, which is only 3 to 4 weeks. And also with operative, you have to splint for 2 weeks and keep that ankle in neutral position. While non-operative, all you have to do is put them in a boot if they have like a painful gait or an abnormal gait, so they're limping or whatnot. So for this case, or for Jack, we chose non-operative because it's not chronic, and he just sprained his ankle for the first time. So we're just going to do a non-operative treatment. It's less invasive. It's less recovery time, so he can get back to work and get back to playing his intramural soccer.
All right, these are our rehab plan goals. In phase 1, we want to protect joint integrity and control swelling and decrease the pain. In phase 2, we want to restore range of motion and flexibility, normalize gait, and increase strength and proprioception. And in phase 3, we want to restore full range of motion in all planes, restore their agility and endurance, and get them back to doing sport-specific exercises to full functional ability. All right, in phase 1, our goals are to decrease ankle girth measurement to 22 centimeters by April 5th. We also want to decrease pain to 2 out of 10 by April 5th. And we also want to maintain joint integrity and not prevent any further injury. Modalities that we'll use in phase 1, we'll do price, we'll do protection, we'll protect with a brace, rest, ice, we'll do compression with an ACE bandage wrap, and we'll also elevate above the heart. We want to do this to decrease swelling and decrease pain. We can also start some ankle pumps in this exercise to help flush out the swelling in the ankle. They can do that while they're elevated. And we can also do toe curls to start to prevent deconditioning of the intrinsic muscles of the foot, and that can also help flush out any swelling. And we'll maintain joint integrity using crutches. So he presented with an antalgic gait, and using the crutches will help him normalize his gait back. And the brace is just to keep the ankle joints stable and prevent any further injury to the medial ligaments. want to demonstrate ankle pumps, and you can do these while their foot is elevated at a surface to help with decreasing the swelling, and all they're really going to do is actively plantar flex and dorsiflex their ankle back and forth, and they can do this as many times as they want as long as it's not causing pain. In phase 2 of our rehab plan, our goals are to increase dorsiflexion range of motion to 15 degrees by April 12th. We also want to increase plantar flexion range of motion to 40 degrees by April 12th. We want to increase the strength of the tibialis anterior for dorsiflexion and the gastrocnemius and soleus for plantar flexion to a grade 5 out of 5 by April 12th as well. And we want to remove the brace and stop the use of crutches when symptoms and joint stability allow. Treatment plan in this phase can include doing ankle ABCs, where the patient will write out the ABCs using their toes, and that will increase the range of motion. We will also do resisted dorsiflexion and plantar flexion with the TheraBand to increase the strength. We can do isometric eversion and inversion activities to increase strength in those planes, and then we could do single leg stance on his injured ankle to increase his balance and his proprioception. Now I'm going to demonstrate ABCs, and what the patient is going to do is, using their toes, they're going to write out the alphabet. They can do uppercase or lowercase, they can do both, and this is to help with range of motion. So they're just A, B, C, all the way to Z, and Phase 3 of our rehab program is our last phase, and it's towards the end of the phase. So he should have his strength and proprioception range of motion to close to normal, if not normal. And we want to return him to back to practice or just full participation in whatever he's in his daily life by April 19th. In phase 3, we can add in karaoke drills to add in different planes of motion dynamics. We can add in our red light, green light drills to work on his acceleration and deceleration and really work on that ankle stability. We can do step ups and lunges to further increase his strength, and jumping squats. We can add in that for plyometrics and work on his power output.
Alright, so I'm going to demonstrate a plyometric exercise that we are going to do in our treatment plan to work on power output. We're going to do a jumping squat, so you want to go down into a squat, make sure your knees don't go past your toes, and then when they come up, you just jump, and they're going to land back down. This is going to work on their power output as well as help their ankle stability and range of motion. Alright, so a strengthening exercise we're going to do for the quads and hamstrings to get him back out there playing soccer as well as he was before are lunges. So he's going to step forward with one foot, keeping the other foot behind and bending both knees to 90 degrees. And then he's going to step back up and then repeat with the other foot, going back down to 90 and coming back up. Alright, so another functional exercise we're going to do is step ups. This will help him for going upstairs when he's at work, also help him with ankle range of motion, as well as power in your legs. So what he's going to do is he's going to step up with one foot, and he'll step up with the other, and then we'll step back down. You want to make sure he doesn't jump down, he doesn't lose his balance. You don't want your object he's stepping on to be too high, and then he'll just repeat